Chào các bác sĩ, tôi là Song Ju Kim, Hàn Quốc, làm việc với chỗ làm việc ở Hồ Chí Minh 9 năm rồi. So today I like to speak upper eyelid blepharoplasty. So there are kinds of lead surgery technique, and today I'm gonna talk with upper lid blepharoplasty for non-incision and incision. There are many these surgeries. Hopefully, I can talk it later again in here for ptosis, for visual ptosis, blepharoplasty. So when the patient comes, you have to check and choose which surgery are you gonna do. Means we are ophthalmologists, always just focus on the slit lamp. So khi bệnh nhân đến, người cho bạn the slit lamp. But for the oculoplastic surgeon, we have to see mặt, sao đố mặt. So check the whole face and check the position of the brow, check the position of the lid, check the position of the skin, so you can get many information from the patients. This is not even for the blepharoplasty, so you can get many information for the eye disease too. So please check the face first and go to the eye exam. So, but there are many factors, which means the cut, high come cut. So means rat, high come rat. So incision or non-incision is a man or women. And considering the age, usually the young patient, người trẻ prefer non-incision. Người già đối, choose the incision và cắt giả. But this is not always. But before that, you should check the ptosis. Ptosis is the single most important factor. After considering this, you can decide what kind of surgery you're gonna do. So ptosis measurement is easy, like this. In here, we just check the levator function. If the levator function is poor, after simple blepharoplasty, the patients get more higher hymen on that side. So commonly done by just plastic surgeon does kind of surgery a lot and make the patients complaining of hymen long. So, and also you have to check brow position and wrinkles, and so keep talking to Sam Matzo. This is brow line. So she got the surgery from the other plastic center, but he missed the ptosis, and surgery is come back. Also, check. He's not a gangster. He looks like gangster, but this is due to the wrinkle. So if the patient has wrinkle, that means high possibility of ptosis. So we have to correct the ptosis and blepharoplasty at the same time and get the wrinkle away. So he's only 32 years old. But before this, it looks like a 50. Now he's returned to 30. And if you miss the ptosis, this is the ptosis on left side. So the faint line and more higher, high knee, long hơn, mặt trái. So we correct both levator resection and toe fold again, and bên nhắn quỳ. So this is the terrible case done at the other plastic surgery and referred to me right after surgery because he missed the ptosis and he did mistake. He didn't repair the levator function. So after blepharoplasty, patient come like this. So if you miss the ptosis, the result will be very terrible. So if patient has ptosis, so do both ptosis and blepharoplasty at the same time, and patient will be happy. So this is kind of the patient who has a ptosis. So see this here, wide. So after surgery, narrow, and eyelid looks good. See the wrinkles, wider, and after surgery, going down, and wrinkles disappear. So this is the good result with doing the blepharoplasty and ptosis surgery. So don't forget, you have to check the ptosis before you do blepharoplasty. And there are also some fake ptosis, looks like fake ptosis, means pseudo-ptosis. This is a list of this one. And we are missing sometimes facial palsy. Previously, the patient had, but sometimes patient doesn't remember or doesn't know he or she had the facial palsy. So that's the point you have to check by the doctors again. So, and in Asian, especially Korean, patient has a very high Mongolian fold, epicanthal fold, and skins cover the lid margin. She looks like ptosis for left eye, but no, because check the brow and wrinkles, everything is okay. But over skins on the left side a little bit more. So what we're gonna do is medial canthoplasty and make a small double blepharoplasty with cut the incision a little bit more on left side. So there are many pseudoptosis. We'll talk later for the lid rejection and hypotropia. We can fix this. And what do you think? What's wrong with her? She came to me she had done surgery before, the plastic surgeon, and she doesn't like it. Yeah, surgery went fail. She has a ptosis. No, she had a trauma before. So the orbital wall, medial orbital wall fractured. So eyeball is sunken. So inophthalmos. That was the cause. So for this patient, what are you gonna do? Lid surgery again? No. We have to repair the orbital fracture first. That's what I did. Much better. not complete because she had an old scar. So I cannot fix the, like a previous her face, but much better to correct. So this is not done by the double fold surgery. Fix the orbital fracture. So for these slides, there are many. So how can you choose? Incision or non-incision? So usually, we don't nói là good candidates là thin skin, thấp, yeah, thấp, not much bulging or orbital fat, không nhiều mỡ đi, and faint previously has a faint double fold line. Hai ní tự nhiên nhưng mà không chặt. So, but this is not absolute indication. Non-incision will include a young patient, right? But, so, if the patient young, see the patient, but, wow. What are you gonna do? Cut, incision or non-incision? People usually say, oh, non-incision will be better for her. But no, I do non-incision. Very suture technique, and she's happy. She's happy. So there are some tricks. We'll talk in later on the video. So even though the patient looks, severe without bulging, still we can fix it by the non-incision method. And even the patient is older, like 60, 20 tuổi, still got thể được by non-incision. So there's many reasons from the experience, but okay. So remember this line. The non-incision suture key then ở đây ở U septum, orbital septum. You should remember this line, and we can do the patient with the previous patient. And that's it. The you. We can still do the non-incisional method with this line. Follow this line. Don't go into here. Try to put the needle beneath orbital septum. This is my favorite technique. And some cases it's very difficult to check because the patient doesn't have double fold and hard to make the hai mắt giống nhau. So, and then use the caliper. I'm sorry. Sorry. Back. Okay. Use caliper. Sorry. Caliper. And 8mm, 7mm, and mark the other side at same position. And do. The 3 point, skin, from skin to conjunctiva and go out skin and tie. I'm using the non-observable suture. Observable means bicrete suture. So leave the stitches on the lead, but we cut very short. Sometimes we have a complication for non-incision method. Some granuloma like this, but don't be scared. Không sao. Yeah. For non-observable suture, you only just chỉ the steroid ointment. That's okay. And wait. and for observable suture. But for the non-observable suture, using the steroid and wait, but it recovers several times, just remove the suture at this area only. So this is the incisional method. So we'll make a design and check it again. I use the laser usually in Korea, in Ho Chi Minh City too. It's easy and no bleeding, shortening your operation time, and swelling is less swelling. So take out the skin with the rectoroid and one the electrocutter needle, or I do at the same time with this laser to skin, subacute, and orbicularis muscle. It's once in a time. So that's easier, but I'm gonna show it by the layer by layer to you. So take out all the orbicularis and open the orbital septum here, and you can see the levator white, bright. And some patient, we remove the fat. This is orbital fat. And some patient, again, and check it. There's no bulging in here, but I don't like it still here, bulge too much. So what I'm doing is to remove the fat which is located in beneath the roof, retroorbicularis space, so a little bit higher in Vichira, yeah. So remove this fat a little bit. And those looks better. So with levator skin or levator skin levator.
Excuse me, sir. Can you talk? Can you go back to the last slide, the slide before, so that I can speak to them easier? The fat removal. Where is the fat removal? The second fat.
Retroorbital fat. Retroorbicularis orbital fat. This is the roof. We
yes,
call the roof.
Yeah.
Yeah. This is located in the not inside the orbital septum. It's out of the orbital septum. It's actually just beneath the brow.
Yes.
Yes. So I removed the brow fat. That's the roof. There are suits in lower and roof in the terminology. Okay, skin suture. And finish the line. Check again. Stop. Okay, let's see the video. So previously I mentioned there are incision and non-incisional method. So suture should come below the orbital septum. If you penetrated the orbital septum area, the suture technique is high prevalence of failure. So this is my method using 6 of Eyelid suture from the conjunctiva, and in suture, I pull the lid a little bit lower. That gives a space to the orbital septum. Pull the lid a little bit and come here. Very beneath, maybe the 1 millimeter. And don't tie. Just keep loose. And the tie is very important. If you tie too tight, the berry suture keep penetrating inside the skin, so the downfold is not clear later. So keep the tension and just cut very short, very nearly, and give July. Moment. Okay. And done. There's another technique, another Dr. Kim in Kim's Eye Hospital. He liked to make a small incision, and he used the non-observable suture for like a 7-0 nylon, and he take a little bit of orbicularis muscle to bury the non-observable suture to give the space. And to come through the skin to just above the conjunctiva and come out and go beneath the skin, circular and carry. That's a 7-0 nylon suture. So go deep. Same way. And cut. And bury the suture inside the wound. Like that. Also, very good. And another doctor, Dr. Zhang, prefer the single, not continuous suture. The method is, at least the first time is very confusing, but I'll give the email address in last slide, Zalo, connect me, and if you want, I can send this file to you. So, to come from outside to inside, just finish the tarsal print, and go come through inside. The needle and suture is specially designed for single continuous suture surgery. So come right beneath, and you go to the left, beneath the skin, circular, and go again to the lower, just beneath the tarsal break, and about 1 or 2 millimeter side, come and to come to here, and come again, and again, go and out, and go and out. Keep sewing beneath the skin and tie it. This suture is very useful for the patient who has like a little bit, you don't have confidence that the patient can maintain the suture with other technique. They will make more. And the one thing is the time of the fall means inside. I prefer inside for the Korean patient because of this fall. And if she has a Mongolian fall, we can make it outer But I prefer on-site like this, on-fold. Need some medial contoplasty. And there's some scars here after surgery. Why you see the scars? And the patient doesn't like it. After getting older, the scars getting larger, wider. This is dynamic fold, natural. So which you like? Most one wants dynamic fold, then static fold. Even in closing eyes, everybody can see the scar lines. Oh, you have a surgery. So the patient doesn't want that. So eyelid opening, the skin fold is coming down upside like this. So the remaining amount of the dough fold you can see is only here. So this is of the how do you fix the levator muscle. The skin levator skin, very classic one. Very classic one. Everyone like this method. So even 45 years old, just cut the skin very long. Pointing the levator, what you're gonna do to fix. This video is actually made for the education. So every procedure is very detailed. So skin, levator, skin. And just make 3 and 4. The remaining is continuous suture. See? Very static wound here. Yeah, surgery went well. Surgery went well, but you can still see their static wound. Scar. And this is not a technique. So fix the levator. To dissect optal suture and orbicularis and soft tissue, and use this orbicularis oculi muscle suture first and go to the levator. So this is orbicularis levator, orbicularis levator, orbicularis levator, not skin. One more minute. And skin suture, just continue suture. See, don't fall easily. And this one also do, but this one not in the levator, but we do on the tarsal plate, more deep area. Marking and can cut out some orbicularis because I'm not going to use this patient orbicularis. So we take out some orbicularis with clamp, so less make bleeding. So you can see the clear tarsa plate here. And fix to not to penetrate whole layer, just half thickness and tarsa plate levator. And okay, Kimja, and compenetrate and orbicularis. This one, because we cut out the levator from the tarsa plate, little bit effect of the ptosis correction. You can see later. So fix it. And let's open and skin, just skin to skin. No need to take a levator again. Because the skin is covered by skin, the patient has less scar, less scarring. Less scarring. And patient is a complication. There are many surgery video to take out the fat using the clamp and then cut out, and using the bobby cauterize, right, and holding one part and check it again. So for the patient who doesn't want to leave the scar, we prefer not skin, levator skin. Orbicularis, levator, or orbicularis, tarsa plate technique is better, means less scars after surgery. The scars. This is the scars I mentioned. Skin to skin, skin levator skin. This one folding, continuously folding every year, so scars getting wider and wider. That's why we prefer orbicularis, levator, and spared skin. So there are many cases the bad operation result, and very difficult to fix the scar tissue. So we have to take out all these scar tissues, very hard, and find out the clear, virgin levator muscle. So this is very difficult sometimes for the beginner. So take out and excise and remove all the scar tissue and make it free and give them more space. This is all scar tissue. So find out the very clean, virgin levator muscle, finally. And fix the levator a little bit more. And fix the levator at the tarsa plate. This is the ptosis surgery. first. And keep doing. So orbicularis, nasal plate elevator, suture. Right. And check it out again. Oh, that's better. And just skin to skin to avoid the scars again. So this is immediate post-op. We remove all the scars and yeah, patient satisfied. So this is the non-incisional blepharoplasty photos pre-op post-op. Pre-op post-op. Pre-op post-op. This is incisional. Yeah, pre-op. Pre-operation. So this is also incisional with medial catoplasty because I hate this line here, Mongolian fold, epicanthal fold. So this is the last slide for me. So to decide which method, that is not important. So make sure you check the patient face. Don't forget face. So, okay, thank you very much. Contact Yellow or email me and